Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Ryan Howells. He's principal at Leavitt Partners and helps to lead the Karen Alliance. Welcome, Ryan.
Thanks, John. Great to be here.
Yeah, lots to talk about. I think, we probably could do a 2 hour one like we did with Brendan, but we don't have time for that. But I'm really interested to hear your perspectives and everything that's happening in the world of health IT, especially health policy. But before we go there, tell us a little bit about yourself and Levitt Partners.
Yeah, so I've been doing this for far too long, but it's an opportunity where I have been involved in healthcare technology my entire career. At the dawn of the internet, John, actually, is when I started this whole thing and said,
Wow.
this makes a lot of sense. And I worked at a health plan trying to get claim status online, that was a brand new thing, super engaging, really cool stuff at the time, provider directories. And moved on from that to work at product companies. I was GM for a product company for a period of time. In the last 10 years, I spent at Levitt Partners, where what we do is we actually form these multi-sector alliances to try to solve really difficult issues in healthcare that typically relate to some type of federal policy that needs to either be written or changed or modified in some way. So when we go to the Hill or we go to the administration, whoever's in the White House, we kind of talk to them about and say, hey, listen, we've got an idea here. It's got multi-sector support. Here's what we're thinking about doing. It's typically very much bipartisan, which is very rare, as you know, these days. But any of these technology topics appear to be kind of in that bipartisan bucket. And that's kind of what we do. They're membership-based alliances. That's how we get paid. And we also provide services to clients in terms of reaching out to them and finding out what their needs are and being able to help them navigate this whole federal policy landscape, which, as you know, in the last year plus has been very, very active.
Yeah, they definitely have stepped in on the gas in different ways, which is interesting. But it is fascinating to think about what you just said, which is that health IT has always pretty much been bipartisan, minor tweaks of how to approach it and how to address it. It kind of reminded me when I started blogging about healthcare IT, right? In the early days, I'm like, well, healthcare is going to be around, and are they going to apply technology to improve healthcare? Like, yeah, I think that's going to stick around too, right? Like, and so to that point, it probably makes sense why it's bipartisan. Like, who's going to go to DC and say we shouldn't use more technology in healthcare?
Or we don't want access to the data, right? Like, actually, we don't need access to any of the
Yeah,
data.
maybe we shouldn't share data to improve
Yeah,
patient care. That
that's
that would
right.
be a death knell.
That's right.
Interesting. Well, tell us more about the background of how Karen Alliance and maybe some of the other initiatives you're working on kind of came together and how you got to where you are today.
Sure. So, as I mentioned, Levitt Partners, founded by former Secretary Mike Levitt, he wrote a book called "Finding Allies and Building Alliances," which is the basis for this alliance practice that we have. We run about 30 of these a year. On the technology front, the first one that we really did of significance was the Karen Alliance. Karen is actually an acronym. Uh, uh, and I can't even remember what it is, John. Creating access to real-time information now, I think, is what it is.
Uh-huh.
And we kind of inherited it from somebody. And anyway, now we were thinking about renaming it, but you know what? It's now in federal regulations, so we gotta go with
People
it.
know, Karen. There's no need.
There you go. It's okay. So we started in 2016. 2016 was when the 21st Century Cures Act got passed, and it basically said, look, you need to have access today without special effort using these application programming interfaces. We actually, the first Karen meeting we had in May of 2016. So May of this year is 10 years, which is insane, John. And we have an opportunity, and we thought we'd solve this problem like a long time ago. But the Karen Alliance vision was, how do we get consumers digital access to their healthcare data where, when, and how they want to achieve their goals? And what it has become is the ability for a consumer to choose any app of their choice to hook up to any Fire API, clinical or claims from any payer provider in the country, hopefully, ideally, using some type of a single sign-on. And that enables them to then say, if I can aggregate all my data to an app of my choice, then I can then be able to make better decisions for myself and my family. The byproduct of that is what Be Well and OpenAI actually announced 2 weeks ago. Be Well is a member of the Karen Alliance. And full disclosure, I'm an independent board member as well in Be Well. And then Anthropic and HealthEX. HealthEX is also a member of the Karen Alliance. announced their partnership where now an individual consumer can get on, they can aggregate all their data, they can use the tools of AI to then be able to interpret that data and interact with it in a chat GPT-like format. And the privacy, security, and consent associated with that far exceeds HIPAA. It's actually HIPAA uses the floor, not the ceiling, because of things we've done like the Karen Code of Conduct and other things related to that over time. And so what's super powerful about that is that we now have data that's more privacy preserving, secure, and again increases the privacy and security that we've had in HIPAA outside of HIPAA than we do inside of HIPAA, and the patient now can engage in their healthcare like never before. There has been overwhelming demand, John, on these two organizations in terms of how many patients want to engage. And that's just because they saw the news article and got on and be able to do that. But I think OpenAI was public about this. Their site crashed on day one. So, and it's interesting because historically, John, you've heard the back and forth around, oh, patients don't want access to their data. They don't need it. They're whatever. Couldn't be further from the truth. And so what we've learned, John, in this group is a couple of things. Number one, we can actually get this to work at scale, and we can modernize the healthcare data ecosystem on these FHIR APIs, which I'm sure we'll talk about how this is happening with CMS and ONC. And in addition to that, we're also proving the fact that this group in the Karen Alliance is actually have more experience with FHIR APIs in production than anybody else in the country. So we know what's going to happen before it's going to happen because this group of apps, there's about 47 of them. You can view them on a website called myhealthapplication.com, where they've been able to get access to this information and really waded through the wilderness to try to get access to the APIs, find the person in the organization who you need to, get access for that information and get the permissions necessary to do that. But they have really been able to provide a way for everyone else to follow along. And now there's a rule called CMS 0057 rule and the e-prior authorization rule. By January 1st of 2027, all payers and providers are going to have to exchange data. CMS payers and providers are going to have to exchange data for prior authorization and clinical and payer data exchange. And that's going to be FHIR related data. So it's interesting, John, that we were kind of at that forefront of where was all going to go. We saw things like digital identity was a thing 7 years ago. We saw things like FHIR APIs. We saw things like, developer portals and how important they are. We've kind of seen all that stuff, and now it's really all coming to pass.
It's interesting to hear you describe that because, you even said like patients want access to their data. I kind of view it slightly differently. OpenAI, ChatGPT, and Claude, right? Anthropic, they showed that people want health answers. And they were able to give answers without any access to any of the person's health data, or the person gave their health data manually, right? And they proved that demand was there. I'm interested to see. I mean, that's the open question for me with this is, okay, now that they're partnered with Be Well and and with Health Excel, right? Is their name?
Yeah.
Will having easier access to the full health data, will that improve the responses? I think we all think it probably will. But to me, that's still a question that's out there, right? Is how will having access to all of your health data actually impact the answers that ChatGPT and Claude are able to give the patient? So it's interesting. Like, I don't know. So it's nice that, because before, imagine 10 years ago, if ChatGPT and Claude had come on board, they wouldn't have even had this opportunity to find out if access to health data. So is that what makes you excited? Is like, hey, at least now a lot of the health data, which it's not all of it, we could dive into that, but a lot of the health data is available to these applications to be able to see, hey, how can we improve the answers, the information that you're given if you have access to the health data?
Yeah, I would say it's contextual awareness. And the reason I say that is because yeah, sure. Everyone gets into ChatGPT. I think 20% of something of their searches is related to health in some way, right? Something is,
Yeah.
wrong with me. I've got a rash on my eye. I don't know what this is, or a rash on my cheek or
Yeah.
something.
I've done
And
one.
everyone's done. Yeah, exactly. And not necessarily PHI, it's just like things that you want to know about. And where do you go? It kind of steers you in the right direction. Sometimes it's right, sometimes it's wrong, but you kind of have to just manage it with the other web searches that you do. I think the thing with this is that, especially with those with chronic diseases, John, like you need to have your entire longitudinal health history actually loaded into some type of common data store and then be able to apply AI to it so that you have all of that context as appropriate to be able to know what to do next. And the challenge is most providers that you go see do not have your longitudinal health history of the last 10 to 15 years of where you are at. Different EHRs, they don't maybe talk to each other. You have to fill in clipboards everywhere you go, so it's not a thing. But now what you have a chance to do is like have it in a way that does it. We've told people, John, before that the only thing constant in healthcare is the person. That's it, right? And so if the person's the only constant, the person needs at least a copy of their healthcare information. You want your provider to have a copy,
Sure.
obviously. But we've learned a lot from that. Why doesn't your provider have a copy? Well, there's this thing called HIPAA, which actually starts to potentially prevent data exchange because you have to have these data use agreements in place, right? And all
Mm,
these contracts and fees and negotiations and all these business model conflicts and all these things that kind of happen inside of HIPAA. But when the patient accesses the data, the patient isn't a covered entity or business associate. So they can just say, give me my data. And
yep.
HIPAA's has individual right of access that started in 1996, but there was no technical, reasonable way to get that data until now. Until now, we've got an app, we've got APIs, we've got identity, and we can come in and be able to access it for ourselves.
Yeah. It's interesting the evolution. I prefer to just say that HIPAA is often used to block sharing, not that HIPAA itself is a blocker,
I
which is
think
a
that's right.
subtle
I
difference
think
of.
that is right. And yes, that is definitely true. And it's used an excuse, right, to do that. It's used an excuse not to send data to patients as well, right? As so, and that's been a concern. But it does actually, there is some blocking associated with that just from the standpoint of the fact that you've got to get lawyers in a room to hammer out a data use agreement, right, to make this work. So that is indication of some blocking mechanism because that takes months or years to work out sometimes, right? So, and then the question becomes, how do you scale that across the country? It means you've got to have data use agreements across the country. Now, hopefully TEFCA, and we'll get potentially that to common agreement, that's going to help in some way, shape, or form because it's the single agreement they're doing it. But for payment and operations purposes, you still have to have some kind of data use agreement between payers and providers. Because last time I checked, John, they don't trust each other that much. That's been the problem, right? So, like this ability for us to be able to share data between payers and providers require lawyers in a room to make sure that they use it for the intended purposes that they need to use it for. And trying to scale that across the country becomes really hard.
Yeah. And what's bothersome to me is that most patients think this is already happening. That's what I think is so fascinating. It's not that they're mad that it's not happening. It's not that they're mad that sharing is happening, right? Which
Yes.
is fascinating to think about. You talked about Kill the Clipboard. You wrote a paper called Kill the Clipboard back in March of last year. And CMS has named their initiative after it. So I'm interested in in your perspective about what was in the paper and what is happening in the health tech ecosystem work groups today, because they embraced a lot of what was in that paper. That's my take. And I think that's a lot of people's take is, they used your roadmap, I think is how I would describe it. But I'd love to hear your perspective, kind of what are some of the key elements of that paper that are being, kind of adopted and implemented in CMS's efforts.
Well, first I'd say they were our ideas, meaning the collective ideas of many, many people for many, many years. Like most of those ideas were not new. They were
Sure.
just ideas whose time has come. And
Mm-hmm.
we had, when we wrote that paper, we had input from payers and providers and patients and IT companies and all kinds of folks, representative sample set of how we would do that, and just said, look, these are just a set of good ideas. So if the new administration's coming in, the previous Trump administration was certainly focused on healthcare technology and Blue Button 2.0 and all the things that they did there under Seema Verma. And then you say, well, if this administration, let's assume that that's the case, that they want to work on some technology stuff, Here's a list of good ideas. So it was really about the community's ideas. I would say though, there's been some really innovative things that I think were in that. One of the biggest recommendations we made, John, is that, and this again came from multiple sources, is that the CERT program that ONC runs is antiquated and out of date and needs to change. And the reason we said that is we did that because when the CERT program, as you well know, was first started, it was started to be able to ensure patient safety across these EHRs which were being built. And the government thought that wanted to be able to ensure consistency in terms of functionality inside the EHR for a lot of different reasons, right? They wanted to make sure they were getting what they knew what they were getting when they were paying for it, right? Whether that's right or wrong, that's what happened. 40 billion plus billion dollars was spent. And then you say, but wait a minute, we still have that same program today, and 96% of the hospitals actually have an EHR. These things are built. They don't need to be built, they're built. Now they're changing over time because of customer requests, as they should, right? Product roadmap stuff. But the big issue is that there are certain pieces of functionality that we necessarily don't need anymore in any Fire-based API world. Don't Let me be clear about that. Don't need to be certified anymore in this
Mm.
Fire-enabled world because there is widespread acceptance of it. So, for example, CCDs. Like, I think everybody wants to get to Fire APIs, but they know that today you need to exchange data via these CCDs. So if you're a new company, a new emerging EHR that decides you're going to come and think, the fact you're just jump to Fire and ignore CCDs, which means you don't have a market for that, right? And that's the logic that ONC put into their recent rule in HDI 5 in December as to why they're going to go down that path. But we also so the question is, how do we actually change the certification program to begin to certify the interfaces, specifically these what's called G10 APIs, not the functionality inside the EHR? I think for too long, John, we have beaten up on EHRs because the way in too much, we've beaten on them too much because of the fact that everyone thought that was the only solution. We
Mm.
need to change the EHR. We need to interface with it. It needs to be changed the functionality. We need to add more functionality because that was our only path in. Everyone that billed Medicare, Medicaid needed to have one of these things. So everyone piled on and said, what's going on? And then the EHR had a problem. They had two masters, their clients, which is always their master and should be, right? And the federal government. So they were always waiting from a product roadmap perspective to get the next rule to
It,
drop.
it's so funny you say that. I mean, you're taking me back, right? Like, this was even before the stimulus money when CCHIT was the main certifying body. I went to a HIMSS conference and a guy came up to me and he's like, "Why do you hate CCHIT?" And I was like, I don't really hate it. I just don't think it accomplishes the goals that we want, right? And then another article that I wrote, and this was after the stimulus money, and as we were getting into meaningful use and EHR certification, I said we should just get rid of all of this and just pay them to share data. Because guess what? You're not going to share data if you don't have an EHR. You're not going to do that on paper. So you're going to adopt an EHR. I mean, so the same idea. Like, why are we being so prescriptive of functionality? Why don't we just incentivize the thing that we want to, which is sharing data, which doesn't have a natural incentive in healthcare? It sounds like that's where we're headed. Is that what you would describe it as, like incentivizing through regulation, I guess, in some ways? There's no money behind it, and at least, anyway, there's I don't know what the $50 billion rule is, but anyways, but there is certainly penalties and other things associated with it. But is that what you see happening? Because it is fascinating, right? ONC's HDI5 eliminated over 50% of EHR certification requirements, right? So, like, where do you see this going next?
Yeah, 100%. So, David Brailer and David Blumenthal, initial ONC coordinators, helped us start Karen. And one of the things they have told me repeatedly is that one of their biggest regrets is the fact that they didn't actually certify interfaces and encourage interoperability at the early stages of where we're at with meaningful use. And so I think that, look, for us to be competitive in this marketplace and for us to be able to, all of the billions of dollars that VC companies are actually dumping into these startups, right? And the promise of AI, the promise of cloud technology, the promise of apps, all of the promises of that say we just need to make sure that the interfaces between the systems are consistent. Because your development of your black box, whatever that is, your widget, whatever that is, your AI agent, your app, your EHR, your claim system, all of that, and I know claim system is part of ONC regs, but all of that can be done. That's what you're selling to the market, and that's what you need to compete on, and that's price, product, and service, right? But the interfaces have to be consistent. And the way that those are consistent is by making sure that they are in compliance with the regulations. And that's really what scales in healthcare. So, if I want to send data from my EHR or from my cloud or from my app or from my AI agent, wherever I'm sending it from, I need to figure out a way to do that and make it sure that it's consistent so we can have interoperability. And I think there's a way to do that. So yes, the answer is I think that's exactly where we're going. And there were some nice kind of Easter eggs in that HTI-5 rule. Number one, as you mentioned, they eliminated 50% of the cert requirements. And I think largely that was to do with the fact that the administration also said that you've got to eliminate 10 regulations for every new, one that you create. And so then they're saying, okay, well, then if that's the case, it appears that they're kind of clearing the decks for the next rule, HTI
Mm,
6, which I think is probably, in my estimation, John, the most anticipated regulation that we've ever seen out of ONC. Because if they
interesting.
do go down that road and actually certify the interfaces, they gave some kind of some Easter eggs in there about the fact that they're looking at API performance, they're at scalability, they're looking at actually read-write capabilities too, as well. These are all like dreams that people have had for a long, long time that now potentially could be a reality because this administration has prioritized it. And this allows for us to be able to say, maybe we can have read-write capabilities and modern technologies, internet-based technologies and APIs, and I could have my data again in my EHR instance or it's on-prem, and I can have it in the cloud, and I can have it over here, and I can do with it what I need to do. I think, John, to be honest with you, if that happens, it will unleash more innovation we've ever seen in healthcare tech, ever, ever, in the whole time that you and I have been doing this, because now the health systems will have options. They'll have multiple options where they have the data, where the use cases are. EHRs are going to do their thing. They're going to continue to be able to develop great functionality for their provider customers, their clinicians. But then others are going to be there too. They'll be able to pull this off the shelf apps or AI agents to also do other use cases that maybe the EHR can't do. And it relieves, to me, some of the burden off the EHR where we're not piling on the EHR every time and saying, why haven't you done this thing? We're actually saying, actually, no, provider, now you can control your destiny, right? You can say, what do you want to do? Which solutions are best for you on the use cases that you had, and allow a free market to actually flourish at that point, both inside the EHR and outside the EHR. I was really pleased with the fact that the EHR Association and some of the EHRs themselves have come out and very much supportive of this, John. I think, they've seen it. They've seen this idea that, they don't want to wait for the next regulation to see what they need to put on their product roadmap, and they want to innovate more for their clients. So I'm just excited because I think that it's really going to usher in the era of innovation.
That's interesting. I'd love to hear more about why you think that's the case. And how that's going to impact EHR vendors, health IT vendors. Because from the EHR vendor perspective, I think you're right. Like so many of the certification requirements, they're done, they're implemented, they're using it. Like they just didn't make sense anymore. It was just a burden that wasn't even needed, right? Is this a new set of APIs going to be an additional burden on EHR vendors? But I think you're describing the innovation that's going to happen for other people to be able to access that data through APIs and be able to do interesting things on top of that data. I mean, at one point I told an EHR vendor, I said, here should be your API strategy. I said, if someone could recreate your entire EHR using your APIs, then you've gone far enough. I was like, start there and then work backwards. Like, oh, maybe there's some things like login. Okay, maybe I don't do that actually, or whatever. Right? I was like, it kind of seems like that's what the certification requirements are going, which is, hey, if I wanted to recreate your whole EHR, I could using the API. Is that too far, or is that kind of where you see it headed?
Well, I will tell you what the health systems are telling us, John. The health systems are telling us, hey, listen, we have things we need our EHR to do that they're doing today, and we need to have things that we need our EHR to do that they're not doing today. And we're kind of waiting for them to do it, right? And that's, by the way, in any industry, any product, that's the
Yeah,
same anywhere, right? That's
of
nothing
course.
against EHRs. That's just the way.
EHRs have to choose. They have 1,000, 10,000 things that they could do,
That's correct. That's
and some of
exactly
them are
right.
really niche.
That's exactly right. That's exactly right. And they're limited, right? That's why I go back to my comments earlier about we've been putting way too much pressure on them to say, I need you to solve every problem in healthcare. Like literally, haven't we been doing that for 15 years? Like I need you to solve every problem in healthcare because you are the clinician workflow. So all of these have to be, value-based care. You start running through the list of things we've tried to do over the years. We
Sure.
need you to solve all these things. Are you kidding me? Like that, I wouldn't put that on any sector. That's super hard to do. Now, some have done it better than others. Many of them have done really well. So that's great. But my point in all of this is to say there are, again, things they want the EHR to do, things that they are doing for them today. And then there are all these things that maybe the EHR doesn't do well, right?
Mhm.
Uh, Potentially value-based care contracting and risk adjustment and all the stuff that, folks like Arcadia and all the things that they're doing in terms of how providers actually take on risk. That's not a traditional function within EHR. There's some EHRs that provide that capability today, but what I would say is that and I could go through a myriad of other pieces of functionality, quality measurement reporting, all the stuff that happens, outside the EHR, where again, I'm not making generalized statements, just that's maybe I'm making a generalized statement, not a specific statement on EHR. But the idea is that these health systems have said we have other use cases we need to solve for. One other thing, John, that's really important here. A major health system told me that in the next 5 years, they're going to have 1 million of their patients lose PCPs, um, and they have nowhere to put them. Cannot reassign them to any other PCPs. And so they told me, they said, Ryan, interoperability was like number 49 on our list of 50 priorities right before. He goes, I'm just being honest with you. I know it's number one for you, but it's like number 49 for us. He goes, interoperability, data exchange, and AI is literally number one on our list. And I'm like, why? He told me this story of the 1 million patients. And he says, if we can't extend our clinicians to the point where they can be able to see more patients with the advent of AI as an AI assistant, right, for them, go from a panel of 500 patients to a panel of 5,000 patients, for example. That wasn't his words, those are my words. But let's say they could do that. If we can't do that, all of these people are going to lose their PCPs, and we have no supply coming down the thing. We could argue why we don't have any supply in medical
Sure.
colleges, we don't have enough residencies and all that stuff, and that's all true. But we just don't have anybody coming. So what I'm saying, John, is that now some of the leading health systems are telling us this is a survival situation. And we have to do this for our own survival and for our patients' well-being, because more people are going to be in primary care deserts than there are today, which would be catastrophic.
Mm, that's interesting. There's a lot to chew on there. I think we could talk about, but it's interesting to think about how is that going to shift how a health system approaches their IT efforts? I mean, it's fascinating how once certification and meaningful use came out, everyone discarded their own EHR. I mean, even the biggest organizations that said, "Hey, we're going to buy off the shelf," right? And we saw this shift, and many of them had huge development houses and everything, right? Building all sorts of really unique, uh, personalized products. Are we going to see kind of a return to that because of this kind of future API enabled app and AI driven future, or what does it mean for health systems that now they have this opportunity? that they could take or not, I guess is the other one, you know. Many of them are in that mode. Hey, I'm doing my EHR, and if they don't offer it, I don't do much beyond that, right?
Yeah. Yeah, well, most health systems are saying, or a lot of the bigger health systems, I should say, are saying, listen, we've got our own kind of cloud-based data store. We can aggregate all the information, to your point earlier, from an API perspective from our EHR to use for other non-EHR purposes. Like we'd like to do that first. So I think that's kind of step one is make sure you have that cloud-based data store. I think step two is like, do you have an API gateway? Do you have an API server, right? To be able to, that's how we're going to communicate in the future. CMS said they're going to build an API directory for the whole country. And that should be, it sounds like what they're saying publicly is going to be released this year. So if that's the case, then we should have our own API server as well so people can connect with us and a developer portal too, by the way, and a test sandbox. Like that's our new future. And then the third thing is we've got to have digital identity too. I got to know that you are who you say you are. I got to know what organization or individual you represent, and I got to know what data you're authorized to receive. If I got those three things, John, I can now compete in the internet economy and I can have more control over where my data goes and who accesses it. And we can have trust in the ecosystem too, because it's not centralized trust, it's federated trust. Now I can say, oh, I can figure out who these people are across these different systems. So the answer is yes. And then the question becomes, what do health systems actually build on top of that? I, to answer that question, John, I would say historically in healthcare, we have just had a proprietary model. Everyone goes and buys their own proprietary widgets, and they try to bolt those widgets together in some way, shape, or form, right, to make that happen. And and that's what we have done, and that's how we have operated, largely because of the CERT program that requires folks to have a specific system that has been certified by the federal government and has the functionality that's required by the federal government. But we have a friend of ours, a friend of mine who runs a value-based care company and started his own value-based care company, said, I can't buy any of these EHRs because they're all fee-for-service based. I got to buy a value-based care EHR, and they didn't exist at the time. So he goes, I had to build my own, and I got to have a fee-for-service EHR. So I got to have two. Well, for those situations, now as long as the interfaces work, then we're good to go. And I think you're going to see an era of open standards collaboration.
Mm.
I think you're going to see an era of, Fire APIs are one example of that. They're an open standard. It's not like X12 that's proprietary. It's not like others that are even NCPDP that's proprietary. Fire is an open standard. Anyone can use it anytime. And that enables it to scale because the feds can actually point to it in federal policy. Well, when that happens and you can actually have these open standards, you can have more open standards. There's great companies out there that are offering API gateways as open source solutions, API endpoints and tooling related to how that actually operates, data models that are actually open. Graphite Health is a good example, Tuva Health from a reporting perspective, or another one called MedPlum that actually offers all these API. These are all open standard stuff that people can take off the shelf and build things with. And I think you're also going to see open AI agents too,
Mm.
that are going to allow for the ability for these health systems to then use these AI agents for common things that they need to use it for, whether it's prior authorization or other things. Um, we've never had really an open source community in healthcare. We've had the proprietary for sure. We just haven't had, it's like, think about like iOS and Android, right? It's like everyone in the world only had iOS as an option
Yeah.
rather than having an Android ecosystem as an option. I think what you're going to see over the next decade is you're going to see more of an open source Android-like approach where more of this stuff becomes openly available. And last thing I'll say on that, John, and why I feel so strongly about it is that's the only way that interoperability actually works is through open standards and through a standard development organization that actually can support those. And then for the
Mm.
federal policy to say everyone should do that. Because because proprietary approaches don't work and they don't scale and they're not interoperable either a lot of the times because of that. So that's the reason open source is so wonderful. And honestly, that's the reason that actually Apple now is adopting a lot of open source tools that are out there beyond just iOS. A lot of folks don't realize that, but Apple's doing that. They're part of some of these standard development organizations that are like ISO and a few other ones that are publishing these things, and they're
Yeah.
integrating into their core platform.
Yeah. Even USB-C, another
That's
example.
right.
Um,
Well, they fought that for years, actually,
oh
because they
yeah.
had their own thing, and then all of a sudden Android was there, and they're like, "Why don't you go to USB-C?" And they finally did.
Europe kind of held them to the fire too, to your point. But
Yes, that's also
yeah,
true.
it's interesting to think about, right? And as I play it out, it's like the large organizations are going to start developing their own stuff. The mid-size, in rural, that's going to be different. It's going to be interesting. Are they going to buy from the larger organizations? Are new companies going to service all the rural health, to be able to build it? But to your point, it's going to unleash the opportunities for people to be able to do those kind of things. So that's
Well, we have an interesting opportunity here, John, for states that want to take it, which is the Rural Health Transformation Program, right? The $50 billion. All of that is not dedicated specifically to technology, for sure, but there is money available. And actually, there's been some requirements in the funding proposals that said, hey, you should put in some technology stuff in here, like the Kill the Clipboard stuff and other things. You could see that group and seeing rural be the place where that innovation happens. Oh, one quick story, John.
yeah,
Um, we had to go from like web platform, laptop, desktop to mobile, right? That was kind of the thing. Africa did not have a chance to do that. They actually jumped
great.
directly to mobile, right? And then everyone had the phones, and then they got the mobile infrastructure up with the towers, and they never had desktops, laptops. I mean, they do now,
Yeah,
obviously, but like they just went right to mobile and they found a better experience and they were able to release things faster and they were able to scale it faster than we had here in the US. I think you could see potentially something very similar in the rural area, right? Rural, yes, they do have some EHRs and they're a little older and potentially they're not on a certified EHR. There's just things that are happening in rural that's really, but could they jump to a quote unquote mobile-like environment where they can say, let's get right to APIs, let's get right to mobile, let's get right to apps and AI. Could that be a way to actually truly modernize rural healthcare in a way that this becomes scalable and people can get access to this information wherever they are? You could get into broadband and the fact that we don't have broadband everywhere, and all that's true. But the deal is 95% of the country actually has a smartphone. So
yeah,
if you
that's
go down
changing.
that path, you're like you could make this into a really interesting phenomenon in terms of how we think about the future of healthcare data exchange. And then maybe that model actually becomes the model that some of these larger, more urban centers actually adopt.
Interesting. So, do you think we can really kill the clipboard? Do you think, I mean, as much as we've tried, right? I can't tell you the hundreds of companies that have pitched me saying, hey, I have this great idea, John. And I'm like, what's the idea? Oh, what if we kill the clipboard? Like no one wants to fill that out. And they're 100% right. We don't want to fill that out, right? Like no one wants to go in and fill it out, let alone fill it out 2 or 3 times, which is often the reality. But is that really possible? Like, to kill the clipboard, or is it more that that's an ambitious goal and we're going to make progress and you're probably still getting the clipboard?
Well, killing the clipboard is a multifaceted problem, right?
Mhm.
Technology is the least of, I think, our worries sometimes. Did they upgrade their EHR to the functionality that supports killing the clipboard, right? Do they accept the application that's actually helping to kill the clipboard for them? Did they remember what we put in there last time, right? To do that? And did the person at the front desk, were they trained to know where to look in the system to actually be able to see the information too?
My favorite for that is the doctor who said, I love blood pressure to be in red in the upper right corner.
That's right.
It's like,
That's
hey, if that's what you want, you might not kill the
That's
clipboard.
exactly right. That's exactly right. So, like, do the doctors want to kill the clipboard? There's a lot of permutations to it. I would tell you, and it's hysterical, John, by the way, is that even for those situations where they've, quote, killed the clipboard, meaning I don't have to fill out any paperwork when I go in and I've done it all in e-check-in, I get asked the same question still at the desk, and the physician still asks the same question. Now, sometimes they're just confirming what's in the system, which is fine. That makes sense.
Allergies should be asked 2 or 3 times probably as a
Right.
protocol.
Right. Correct. Right. Which is totally fine to make that happen. But I think we're going to get to a stage, John, similar to where we have gotten in patient access, where I can get access to my data and never have to talk to anybody. That's the actual ideal goal. I just don't want to talk to anybody. I just want to get access to my information. If I'm in my pajamas at 9 o'clock at night and just have this information with me, and then I want to share it with my provider if I need to, because I'm going to see my new PCP. Even better, I'd love my provider just to have that all with me
Yeah.
historically. But that needs to be, and I think the same thing is going to go with Kill the Clipboard. I think we absolutely can get to a stage where you are not copying your insurance card information. We in the Karen Alliance, we developed what's called the Karen IG for digital insurance card. There's like 5 million in production right now, which means that the payer just simply sends your insurance information to your PCP that you chose during open enrollment. What a concept, right, John? Like how many companies have started just to solve that issue, right? Like it's
Hmm.
insane. And
Yeah.
that should have been done years ago. There wasn't a standard necessarily in place to help that happen. So we wrote this API standard, and now this is happening at scale. And there's this industry, John, called revenue cycle management, which probably shouldn't exist. And I'm sorry if there's sponsors of your show that are listening that this is the case, but this is
No, their response is it's going to exist because it's so complicated.
there you go. Well, okay, so it's just my opinion. I don't think it should exist because revenue cycle management just means as a provider, I either have to buy a solution or hire people to chase down money I'm already owed. That's basically what it is, right? Because the
Yeah.
systems don't talk to each other. And
Hmm.
so my point is, could we, one health system told me they hire 1,000 people to do rev cycle management. Really? Could we just reallocate those 1,000 people somewhere else? Like that could
So
be an
it's a
idea.
small organization, is what you're saying.
Yes, yes, exactly. And it's like, why can't we just take the insurance information, send it, and certification, by the way, or prior authorization, I should say, um, as of January 1st, 2027, that's going to change dramatically too. And I think probably 40 to 60% of this rev cycle stuff is going to get taken out of the system because of that. On the DaVinci prior auth APIs that are meant to be live on January 1st, 2027, the early adopters have told us 93% of the time the doctor gets an answer back in real time, either yes or no, because of the way that these APIs actually work. So if we can take care of 93% of our prior auth problem, how much money does that get taken out to put towards more better patient care? That's a great idea. Same thing with insurance card as well. You don't have to chase that down. That's automatically either sent from the patient, which is part of the CMS Health Tech ecosystem, or it's sent from the payer. Either way, get it to my doctor, make sure they have that information, and make sure they can bill the plan correctly. That would be great. I mean, that it's amazing that we're here in 2026 and we're talking about that as an innovation. It's just in some ways it's very sad, John. You know that, right?
I do. I do. And, you know, all the scanner companies for scanning those ID cards, they're in trouble. But no,
Right.
it's fascinating to think about. And, you know, and we learned something also. Ryan's an optimist when it comes to prior auth being solved. I hope you're right. But I think, you know, I have my skepticism. Someone described me as a curmudgeon, which may be true as well. Yeah, as we wrap up, I wanted to ask you one question that's a little out there, and I have no idea what you're going to answer. Yeah, luckily I sent it to you so you could think about it a bit beforehand. But is there a shift that's happening right now that maybe not a lot of people recognize, but they should? I mean, you've already mentioned a few when it comes to APIs and certification and some of those things, but and so you know you can double down on those, but is there something you talk to a lot of people, you have a lot of convening with your organizations to hear what's happening. Is there something you see happening that maybe not enough people realize, hey, this is happening, it's going to really impact you?
Well, I think the last year has been transformative in terms of how many announcements were made. We didn't get a chance to talk about the CMS Health Tech ecosystem. Just real quickly on that, there was a press release over the summer. Most people publicly, if they haven't signed up for it, haven't heard anything else about it and thought that it was just a press release that's gone away. There are more than 13 work groups right now that are actively working with over 600 organizations and close to 1,000 people in a Slack instance, multiple channels that are meeting on a regular basis, looking at ways in which they can develop the future of FHIR APIs, digital identity, and what a CMS aligned network actually looks like. And that's all going live this year. So I would say that's the quiet thing that's happening behind the scenes. What that's going to enable folks to do, John, who are, and by the way, to participate, Google CMS Health Tech Ecosystem and fill out the form. That's literally how you participate.
Yep.
I would
And they
just
even
say
have friends of the ecosystem. You don't
they
even
even
have to
have.
be a tech vendor. You,
Are you a friend yet, John? Are you a friend of the ecosystem?
I should sign up. I don't know. It's press allowed, but yeah, I am a friend whether I've signed up or not.
Well, I would say that's going to be very transformative. Even ONC mentioned the fact that like that's the speedboat approach because it's trying things out with our public and private sector partners. And our CMS has made mention of the fact they're going to build an endpoint directory and a provider directory for the whole country. That alone is going to help tremendously in terms of how do I get access to these endpoints so that I can share the data. I think that is and the other thing I'd say real quick, I know you only asked for one, sorry, but is that providers who want more access to the healthcare information in their EHR in their own cloud instance. Um, that is a trend that is very quietly happening, but there are a lot of health systems, far more than I anticipated, who are saying that is something we desire because it's based on our ability to run our organization and to be able to provide effective patient care to the people that we serve. And there's a lot of people that want that. There's a lot of people that have kind of given up on that to some degree. And there's a lot of people that want it because maybe their HR doesn't provide it or whatever the case may be. But there's a lot of health systems that, to your point, I want to switch over to do that. Resources are tight, but they want to find ways where they can be able to provide better services to the patients that they serve. I think those are two big things that folks should pay attention to.
Amazing. Well, it's been a wild year and a half, I think, for those of us in the health tech world, especially for when it comes to policy and implementation of so many of these new things and removal of many things that were done before. I have a feeling the next few years are going to be even more dynamic as people collaborate together. So, Ryan, I appreciate you diving into some of them. I know you eat, breathe, and sleep this stuff the way I do health IT similarly. So it's always fun to chat with you. So thanks so much for coming on. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting applications. Thanks, Ryan.
Thanks, John.